Do you have any age limit for this procedure?
Not age limit, but we know that some people, since this needs a participation in the physiotherapy that is very long, takes months to be to have a regain of not just a proprioception but neuroreceptorial response. So in 85 years old, it is probably not the ideal candidate, but I have patients more over than 70. They are active more than me, and so I think they are not excluded from the population for that procedure.
Yes, please. This.
What about the re-rupture of the tendon? Because we know from the last few years that if we put the tendon too close to the sulcus, you have a lot of tension. And with from publication from French people, now they start to moving close to the infraspinatus, so they reduce the return rate. What is your experience with that?
Yeah, different ways to do that. So if you want to have, as you go to bicycle, you have the fulcrum. You have a different force applied to the spoke and to the hub. So the hub, as large as the hub, is less the force is concentrated. To go to the intertubercular groove needs to dissect far down till to the scapula angle. So someone does not do that. Someone does it all arthroscopically, and you see that there is not any separation between the serratus anterior and the anterior chest wall and the muscle belly. So two different techniques, and the forces are not the same if you put the graft inside a tunnel at the infraspinatus, because it does not go over and it does not counteract properly. Probably the deltoid forces, probably it acts better as external rotator. So, and there is, when you introduce the graft into a tunnel, there's the point, the entry point changes abruptly the path, and that is where you break any material, where there's a change and not a smooth gliding, and there is a change of the not flexible. So there is a concentration of forces. I don't know what is my rate of failures for that. I tried to put some metallic stitches, as I saw from our colleagues, but no comparable different techniques.
But you put it flat, not over the top, but posteriorly. You put your tendon flat on the head, the humeral head.
Yeah, but
and
so you
not
want
over the top.
Not over the top. No. I put it over the top.
You put it over the top.
Over the top. So if you don't, you don't reach the intertubercular groove over the top, you have to release some more. And if you put stitches, and it is stitches two at the top, so anterior, and two medial, as it is possible, someone does it, I sometimes do it, the mechanical effect is that this act for the posterior, not for the anterior stitches, because there is not a gliding, not not a rotation. So mechanically different things we cannot compare.
Too bad Jean is not there.
Is there any
Not
other
yet.
question?
I know,
Just-
but no, this is not against anyone.
No,
So
no.
this
No, no,
is
I don't
probably
take it like
my results are worse than others. But
Can you have a last comment, please, because you have to leave now? A last comment about the partial repair latissimus dorsi. There was a recent paper for Philippe Valenti that he said partial repair that makes sense, also helps with latissimus dorsi.
absolutely.
So, can you make a comment about the repair? You like to repair the latissimus dorsi and then separately the partial calf with no sutures between latissimus dorsi and infraspinatus? Or you like to suture also the infraspinatus latissimus dorsi?
No sutures between the two. And another that why the latissimus dorsi, if you do not repair or repair the remaining infraspinatus, can help the external rotation because over the top has not that function, so huge function. This is because he stabilizes the tendon, the posterior inferior external rotators tendons. So giving some stability to the tendons and to the repair of that.
I have just one
Yeah,
little
yeah.
question. So what would be the place of capsular repair with those patients for you? Because
The inferior,
between tendon transfer, latissimus dorsi transfer, and capsular repair.
in capsular repair, so the
Superior capsular repair. yeah.
superior capsular.
I think latissimus dorsi, it gives the posterior band we're missing, and we said that capsular repair does the same. So, what's the difference for your indication between latissimus dorsi and capsular repair?
Capsular repair. So this is my opinion, my point of view. Capsular repair gets stable what is being. So what is the remnant calf does not do any alone. If you stabilize by stitching the posterior tendons to the capsule, and you can reconstruct a sort of bridge, suspension bridge, the same of the expansion of the coracohumeral ligament, the arcuate ligament. So it can work, but alone would not work. The latissimus dorsi work as a force acting, pulling down during forward flexion in the plane of scapula. But it is not one against another.
Yeah.
We have a spectrum of choices. We have not just aspirin. We have some of the non-steroid anti-inflammatory drugs.
Very good. Thank you very much, Dr. Gervasi. Thank you very much for this talk.